Well, friends, welcome to today's webinar. And today we have Dr. Prakash, who's presenting. He's from Raja Rajeshwari Medical College and Hospital. Dr. Sanjay Mehta?
Yes, sir.
Yes. Can you moderate?
Yes, surely. Hello.
Yes.
Yes, sir.
Hello, friend. Yeah. Welcome you all again for a series of webinars that is intended for CBME in microbiology. Last time we had a session on SLO2 objective. Once again, we will come back to objectives also later on during the course. There is too much noise. I think someone's audio.
Oh,
No, it's fine, sir.
Yes, yes. Okay. So, after objectives, we are starting the objective, remember that. And when we are preparing the objectives out of competency, it is also very important that some of the objectives are merging with other subjects horizontally and vertically. So integration is very important. So we'll also have a look at what is integration and how to take care of that, and which are the different type of integration Medical Council of India is looking for. Right? So next our session, we have Dr. Prakash, is a professor at Raja Rajeshwari Medical College, Bangalore, and we request him to take the session. Over to Dr. Prakash.
Thank you, sir. I would like to thank Dr. Sanjay Bedi, sir, and Sanjay Mehta, sir, for giving me an opportunity to be a speaker in this platform. I would also like to welcome all the participants for this webinar, and my topic is integration of competencies. All of us know that recently we had integrated online teaching as our curriculum due to COVID-19, which was neither looked into before 2 months earlier. So integration is easier to do if we intend to do it. Okay. I would also like to thank my St. John's professors who taught me the CBME as well as CASP. By this, let's go into the topic. So let's introduce what is integration. Just a minute, sorry, please.
you can press the escape button and yes.
Yes, sir. Okay, let's see what are the objectives we are going to learn from this webinar. So we want each one of the faculty must be able to explain the basic terminologies in integration of competencies, and then develop an aligned an integrated microbiology curriculum as envisaged in the GMER 2019. So what are the basic terminologies? First one is alignment. So alignment, it implies that the teaching of subject material that occurs under a particular organ system or a disease concept from the same phase in the same time frame. That is called as temporal integration. Then integration as such. It implies that concepts in a topic or organ system that are similar or overlapping or redundant are merged into a single teaching session in which subject-based demarcations are removed. Coming to linker, it's a session that allows the learner to link the concepts present in an aligned and integrated topic. A harden is a person who has devised many strategies, among which we are going to see one of the strategy today, that is educational strategies. It is called as SPICE module. So each strategy can be represented as a spectrum or continuum. So the first S stands for the student-centered or teacher-centered. The P stands for problem-based or information gathering. I stands for integrated or discipline-based. C stands for community-based or hospital-based. E stands for elective or uniform. And the last S for systematic or apprenticeship or internship-based. Today, we are going to look only into the integrated or discipline-based. So what was happening till now? It is called as traditional teaching, whatever we were doing till now. How was it happening? So you think this as a timetable for an MBBS, so where each subject person was going to take a similar topic at different phases of time, like this. At different months or at different weeks, we never used to be any integration there. So that's the same thing. It may be the same phase or a different phase. They used to take at different times. So what happens if there is no integration? There are going to be piecemeal knowledge. That is, for example, we are given the Coombs test can be done by both microbiology and pathology. So we can omit, some teachers try to omit the Coombs test, saying that they will be done in pathology department, or they may not say something complete about that. And unnecessary repetitions. For example, pathogenesis of infectious diseases, TB, AIDS will be done by both pathology, microbiology, medicine, or pediatrics, etc. Then confusions. The microbiology department, that the students think that we have told 6 types of vaccines for JE, but only one type of vaccine was told by the pediatrics. Such confusions can occur. Watertight compartments. Then we try to say that this belongs to community medicine topic, so it should not be discussed in this class as it is a microbiology class. So let's stick to the department. So why integrated curriculum? It reduces a typical fragmentation of medical courses. It provides a better sense of the unity of information involved in healthcare education, motivates students and shape their attitude, and the basic sciences are something to get through. That prevents students from feeling that they are becoming anatomists or physiologists. They begin to see the relevance of these disciplines to the general practice of chiropractic, fosters higher level of objectives with less emphasis on recall, more on integration of knowledge. It promotes faculty communication and collaboration. What are the disadvantages of integration? Information does get lost in an integrated approach. There can be omission of topics. Teachers may not feel the ownership in the student-centered learning. The teachers may feel uncomfortable as compared to the discipline-based teachings as of now. It requires more planning and oversight as well as time. So this is some of the things given from the MCI. I'm going to refer most of the things what was given by MCI PPTs. So they say that there has to be integration, but what percentage of integration should be done? The preclinical departments, they are supposed to integrate 20% from the clinical sciences, whereas paraclinical, we are supposed to integrate 40%, and clinical departments, the clinical sciences and clinical has to be 20 and 80%. There are some misconceptions about the integration. See, adding different parts together, is it an integration? This is not integration, it's just a summation. Then proper timing of course offerings. There is two topics. If they think that they are almost the same, they can just put in same time or same day. Then they think it's an integration. No, that is a sequencing. Teaching related areas in different subjects together. That is called as synchronization. And teachers from different disciplines teaching together. That is team teaching. These are not exactly integration, but then what does integration mean? So integration is summation, what we said earlier, plus sequencing, plus synchronization, plus team teaching, all four along with a common goals plus a linker. So all this put together is called as integration. So what are the different methods of integration? As Sanjay Bedi sir already mentioned, we have different types of integrations based on the phase of MBBS involved. One is horizontal integration. This is, most of you know that. What is horizontal integration? Exam integration across the disciplines, but within a finite period of time. Example, a combined year or a semester long or a single basic course science courses. This can be integrated horizontally. The other types are vertical or Z-shaped integration, the spiral integration, also called as intentional reinforcement, then the hybrid integration. It is an integration by students. It is a student-centered. Example, the students themselves prepare food for themselves. That's integration by students. Integration by teachers, and the example is mother cooks food for kids. This is some of the integration by the different persons. So horizontal integration, as I mentioned, the pathology, microbiology, pharmacology, all three subjects are going to integrate the topics or organs or systems or competencies or even SLOs or cases. Any of these they can integrate, and at the same time they can do all these topics. That is called as a horizontal integration. The vertical integration, I said the Z shape. Now what we are doing is H shape of integration. That is not exactly happening. So we are moving into the Z-shape vertical integration, where I showed earlier 80%, 20%, and 60-40%. That's called as a Z-shape vertical integration. And we have the spiral integration, where the topics are again visited and revisited, and then they are going to be reinforcement of the skills as well as the knowledge in this spiral integration. And the hybrid integration is either combination of one or two integrations together. So again, Harden, we said 6 education strategies are there, and this person has said there are different levels of integration. Let us see what are different levels of integration. Altogether, there are 11 types of integrations, starting from the smaller one, or as no integration level, to the higher integration levels. We start with isolation, that's the first one. Next, go with the awareness, harmonization, nesting, temporal coordination, sharing, correlation, complementary, multidisciplinary, interdisciplinary, and transdisciplinary. Let's see what is the isolation. Here, organizing teaching in silos without consideration of other subjects or disciplines. You can see the color coding over here. So you have given red, blue, and yellow. There are different departments which are doing at same topic at different times. This is isolation. Each one of the department doesn't know what is the other department doing. They're just following their departmental timetable. That is isolation. Awareness. Here, the teacher in one subject is made aware of what is covered in the other subject in the curriculum, but they are doing the same timetable, but they know that what exactly the other subject is doing. They are not going to bother anything as such. The third one is harmonization. Here it's almost similar to awareness, but a member will be there who can oversee what is the other departments doing, and they try to get something from the other department, but not exactly completely. say deliberately relate curricula with the disciplines rather than assuming that students will understand the connections automatically. Next, coming to the nesting. Here, teacher targets within a subject-based course skills relating to other subjects. They take something from the other department to this class and then they mention about that so that they can correlate with the other subjects. Like for example, again microbiology, we talk about the pathogenesis and pathology of meningitis, and then in pathology department they can just mention about the lab diagnosis of the meningitis overall, which can include even the pathology, microbiology as well as the radiology also. This way, they are going to bring some part of the other topic or department into their department. Coming to the temporal coordination, as we said earlier, that is the horizontal integration. The timetable is adjusted so that topics within the subjects or disciplines which are related are scheduled at the same time. I can see in the month of February, all the three departments are doing the same topic. Next, coming to the sharing. Here, two disciplines may agree to plan and jointly implement a teaching program. That is just a simple sharing, the English meaning word. You can see that here, microbiology and pathology, both of them have decided to take few classes of meningitis in the month of February, whereas pharmacology, they are doing at their own pace. This is sharing. Next is a correlation. Here, emphasis remains on the disciplines or subjects with subject-based courses taking up most of the curriculum time. Within this framework, an integrated teaching session or a course is introduced in addition to the subject-based teaching. You can see here, at January, February, two departments are taking up the meningitis cases, the classes. Along with that, in the March again, they are going to come back and have an integrated teaching. What is complementary then? The integrated sessions now represent a major feature of the curriculum. It's just a complementary to the other classes. Here we can see if it is a few classes in the January and February, the other departments are taking meningitis classes, whereas in March and April, they are going to have a huge session for the integrated sessions. So meningitis integrated sessions will be more when compared to the routine classes in complementary. Coming to multidisciplinary, this brings together a number of subject areas in a single course with themes, problems, topics, or issues as the focus of learning. So in this case, we can see we have got microbiology, patho, pharmac, general medicine, pediatrics, radiology. Many departments coming up together to form a teaching session, whereas they are not mixing up each other. They are doing their part and they are going. In interdisciplinary, the shift of emphasis to themes as a focus for the learning of and to the commonalities across the disciplines or subjects as they relate to the theme. Here we can see there is a merging between the departments. In transdisciplinary, just a theme or a topic or a case is taken up and then that has been put across. That case will be discussed by all the departments. There is no a field of knowledge in this. It's just a real world experience or their experience they are going to share over here and then they are going to talk as it is. It's not a regular class. So next coming to what is the levels of integration. We spoke about level types of integration. What exactly our MCA wants is we want at least an alignment, a temporal coordination, then an integration where they say that sharing, correlation and nesting should be done. This is all they expect from us. At least this is the basic things what we should do. If you are able to do something more than that, it's fine, but at least these three things where sharing, correlation, nesting should be possible to do for us. So for this, how we can go about, what are the things we can do? I'll just give an example with a microbiology competency. Let's check it out. If many of us feel that's fine, that is, we'll continue with that. This I have taken from the Sanjay Mehta sir. This sir said in the last webinar that these are the competencies which we are supposed to integrate from different phases. So keeping this, we can form the integration, how it is going to be. If it is only one department, what we are supposed to do. If it's 2 departments or 3 departments, what are different types of sharing we can do. So this is one of the template which is given by MCA, which says that what we are supposed to do, guidelines for integration. So we can suppose to take a competency to be acquired by our microbiology students. So choose one competency. Those competencies can be linked to other departmental competencies. We have to check it out. If it is yes, we can integrate with other similar competencies in other departments. Then we have to choose either by disease wise or system wise, any one of the things. Then list all the competencies under that in each phase. Second MBBS, third MBBS and first MBBS, all 3 different phases we are supposed to choose the competencies. Once the competencies are chosen, then we are going to review those competencies and we have to check whether there is any repetition of the competencies or any words which are repeated in these competencies, and they have to be eliminated. Once they have been done, the review competencies from other phases and those again which needs reinforcement has to be done. After doing this, we are going to create objectives and then method of instruction. Then it create a linker or integrated session where learners can integrate concepts learned in the block, then allocate self-directed learning time for preparation or assignments that will strengthen our students' ability to integrate the topic, create formative assessment sessions for end of each AS, and include non-aligned and integrated ones. If you are not able to compete with the competencies cannot be competed with the other subjects, then we are going to directly say that this is a non-aligned topic. We have to allot specific time and they are running along with the aligned curriculum. Once all these things are done, we are going to prepare the timetable, which is aligned and non-aligned things, integrated sessions, self-directed learning, and then formative assessment. They ensure integrity of total hours recommended for each subject, integrated teaching, and the SDL has been allotted. Then use integration time allotted for linkers and portions of other phase competencies. This is the overall strategy what we are going to use for creating a timetable, but I'm not going to go in detail about that. I'm just going to restrict myself with the integration. Using these things, I've taken meningitis only as a case list and I've formed a how to integrate ourselves. So let's start. As I told you earlier, I have taken meningitis. So in microbiology, we have these 3 competencies: MI 5.1, MI 5.2, and MI 5.3. These are the 3 competencies which are given under the meningitis. So can these competencies be acquired together with similar competency in other subjects? We need to check it out. In the UGC volume, curriculum volume, what has been given by the MCI. So if we say yes, then we are going to choose the system or organ. We have taken the disease here. It is a meningitis. That is what I have chosen. So step 2. This is the meningitis specific competencies from each subject in the same phase first. So already we have chosen the microbiology part, MI 5.1, 5.2, 5.3. Now we're going to see what are the things in pathology. Pathology we have 35.1, then 35.3, then pharmacology 1.43. I've taken this one. It's not exactly linked to meningitis, but the treatment to meningitis is taken from there. So I've taken it from the pharmacology, which can be integrated here. This is some of the same phase. Next, we are going to see for the higher phase. From general medicine, we have 17.7, 17.13, and pediatrics we have PE 30.1. These are the 3 competencies which are chosen from the higher phase. So then we are going to see in our phase how we can align it. See, this is our microbiology thing. We have taken it, and then we are aligned with the pathology people and pharmacology. So here we can notice that the one of the competency from the pathology has come up and microbiology part has gone down. This is how we can just put the competencies first, then create SLOs for each sequenced competencies. Once we are done with the SLOs, we are going to see is there any redundancy for this SLOs. That is there any repetitions in the SLOs. Now, once we have formed the SLOs, we can see how we are going to integrate. So we already know what is sharing. Sharing is 2 departments coming together and forming a teaching session. So we have chosen the pathology and microbiology. We can see all the SLOs over here. So keeping these SLOs, how we are going to share. So here we have taken up the competencies higher up and lower down. Based on this, we can have either sharing 1 hour, 2 hours, however we want. We can differentiate the classes and then share the classes. Then come to nesting. Nesting, we already said objectives from other subjects are taken up. See here, we have one in our class, discuss the CSF findings in meningitis. In pathology, they can discuss the laboratory diagnosis of meningitis. In pharmacology, they can again list the agents causing meningitis. This way, they are going to bring one topic and then they are going to form a class where only few of the topics are dealt with. This can be done across the phase or even higher phases can be brought into the things and they can create and teaching through nesting. Correlation. So these are the topics as we have already chosen. So how to do correlation for this? Here we are going to add what is called as linker. We are told earlier what is a linker. So what is a linker now? It's a case or a problem or a situation. You can give any of these things. I've chosen a case. A child was brought with a history of constant crying and stiff neck. This case history can be given for the second year students and then it can be continued all through the 3 departments, or it can be chosen even in the higher phase and then they can be asked to continue with this case, or we can have a separate cases for each phase and they can do it. It depends from phase to phase. Or even if you want to do for a first year, we can't give the same case, then we can give a different case. So it depends from the institution, but we want to have a uniformity in the cases if you want. So what is alignment and integration we are going to do based on the competency objective. So what we can do is, if you think this competency cannot be taught in a particular topic, then we have to teach them separately. If you think the competencies can be taught together in different sessions in the same topic, then we need to align them. And if it's a different phase, from earlier phase to reinforce a concept, we can align them. From later phase to introduce a concept or create relevance. And the competencies can be taught in the same session, in the same topic, then we can integrate. If you want to link, then we can use a linker. It can be a clinical condition or a problem or a case, as I said earlier. So these are some of the things what we are going to do, and these are the references where I have taken from. It's almost GMER and the integration ladder what I showed, education strategies, the SPICES model, and UGC curriculum volume 1, 2, and 3, and the integrated medical curriculum and integration medical learning and teaching. These are the references what I have considered for this PPT. Thank you again one and all for all of you. Any clarifications or opinions, please let us know. We will try to clarify that. Thank you, sir. Bedi, sir.
Dr. Mukesh, Dr. Purnima is also here. Dr. Ritu is also here. Yes. There are two hands. Dr. Mukesh Kumar, can you unmute yourself?
Yes, sir. Good evening, sir.
Yes.
Good evening, Pa.
Yeah, nice presentation, sir. A few things I had doubt, so I got clear regarding how to compile those three, yes, the horizontal or vertical competency, and then select the SLOs. So that I got clear it. So that was a questionnaire, but with your presentation, it got cleared. So I think once we'll start doing it, more doubts will come. That time I think because once we start working, then only we face a lot of problems. So I think once the session will start on working, as sir has given the chart, there will be working there. So hope this will be help during that time, sir. Thank you, sir.
And thank you, Pa. I've just
Yeah.
given a model for you. That's it.
Yes, sir.
Yes,
But that will help us, no, sir, that time.
Yes, sir.
Hello.
Sanjay Mehta, sir.
Yes. I would like to add something. Right.
Yes, sir.
Dr. Prakash, it was a very good presentation, very nicely prepared presentation.
Thank you, sir.
Uh,
Thank you very much, sir.
the point which will come up, because we
Yes,
don't
sir.
have ready-made curriculum and timetable which is prepared by Medical Council of India, right?
Yes, sir. Yes, sir.
The booklet has given a competency, and the rest of
Yes,
the
sir.
thing
That's true.
we are supposed to devise. Once again, there will be a big problem with assessment, right? Teaching, learning
Yes,
method
sir.
and assessment. Some guidelines are given which are very broad. So that is the one problem which will come up. So we don't have ready-made timetable. When we are going to prepare that, the physical problems or the difficulty we are going to face together. So over here we are only talking, the group is talking about microbiology, but
Yes, sir.
each one will have to make a team in their institution, and there has to be a weekly meeting with pathology, pharmacology, forensic medicine, and community medicine. These are the very essential things. So then you will be able to work out this thing in a forward way. So that is one limitation. And second thing is that Medical Council of India has said 80% of the curriculum you try for alignment and 20%
Yes,
you
sir.
do integration, right? So
Yes, sir.
so first of all, we need to differentiate the competency which are alignable and non-alignable. Out of that
Yes, sir.
alignable competency, at least 80% we should go for a rather temporal alignment. That is, we are teaching in a same time frame, and 20%, that means few of the topics of the competency we need to go for either nesting or sharing, right? That is all
Yes, sir.
we need to devise it, and we
Yes.
have got enough time for that. So that we are going to exercise along with in our institution along with other subjects. Okay, right?
Yes, sir. Yes, sir. Yes, sir. So
Back to very
I had prepared one chat where we have aligned the topics itself.
okay.
Divided two. One is aligned, non-aligning. Both the things I had prepared, I forgot to put in this slide. I will share it in the WhatsApp, sir.
Surely. And if you can access the slide, you can even present it here, and just for sake of the participant. Any expert view from Dr. Purnima or Dr. Ritu or Dr. Bedi, sir?
Uh, no, it was a wonderful presentation. A
Thank you,
lot
ma'am.
of things, the examples which were put forth were very, very, I think, informative. So I think this is how we have to start, and it's going to be a very long exercise actually, and it will require a lot of teamwork. That is how I understand, and probably the participants will agree. It wouldn't be initially as simple as it looks, and maybe once we prepare um, this kind of timetable, we can gradually, improvise over time. So whatever was presented was absolutely the essence of integration was taken out in this. So congratulations for the wonderful presentation, sir.
Thank you, ma'am. Thank you very
Um,
much, ma'am.
I would like to add to Dr. Purnima what you said, madam.
yeah,
As it has been repeatedly said, this is going to be a trial and error, right?
right.
So when you meet together with your friends, pathology, pharmacology, don't insist that there should be 100% what MCI says, right? It will not be possible initially. It will take few years to get down into this particular competency-based curriculum. Because the moment you try to integrate everything, it is going to create a lot of difficulties, right? That is what we
Yeah, I
have.
completely agree. Yes.
That is what we have witnessed in first year when they had a rigid timetable, and suddenly one subject said that it is not feasible for us to go with this timetable. We need to introduce few other systems also, right? So the thing is that we need to be very flexible, and this will be improvised over years, right? That is the thing which we need to take care of. Yes.
On
Hello.
chat, Dr. Sain Leela has written, we have been doing sharing and nesting in present curriculum. Also, how is it different? We have many bacterial etiology identification of each organism, which takes more time.
Yes, sir. Sorry, sir. Can you repeat the question, sir?
Dr. Sain Leela has
I have asked about how different is sharing and nesting because we are already doing it. That is what has been asked, I guess.
yes.
Yes,
I have
ma'am.
unmuted you,
Yes,
Dr. Sain
ma'am.
Leela.
Yes,
Over.
yes, sir. I am Dr. Sailila.
Yes, ma'am. Good
Yep.
evening, ma'am.
Good evening. Actually, sharing and nesting already when we teach applied on meningitis part, we have been doing. How is it different now?
Ma'am, nesting, most of us are doing it, ma'am.
Yes.
This is the one part. Many of teachers are doing nesting, but sharing not
Yes.
much. Occasionally we are
Yes.
doing it. But
Yes.
nesting, as you said, it has been doing earlier, ma'am. It's the same thing. But we are just saying that
Yes.
it is one of the things which we are doing.
Yes.
Now it has got a name. When we say we
That's
are
it.
bringing in, phase 1 things to phase 3, and phase 3 we are reinforcing, etc. So these are just names now given to whatever we were doing earlier.
Yes.
Yes.
One more thing, madam. So when we take the lab diagnosis of meningitis, in microbiology part, many organisms will come now, like pneumococci, haemophilus, all these meningococci, all these we have to take meningitis. Again, in pneumonia, pneumococci comes there. There also we have to repeat again the same lab diagnosis. The repetition is coming there. How
No,
to reduce
not
that?
really. Yeah. Was this question to me?
Hello.
Ma'am,
Am I
Saitama,
audible, madam?
Is this for me? See,
Am I
some
audible?
amount of overlap will be there, and consider that talking about the same organism twice or thrice, it will lead to a lot of reinforcement. Next time, when you are talking
Yes.
about pneumonia, you don't need to tell them. You ask them that you already know about
Yes.
pneumonia. Now you say, what is the lab diagnosis, and how will you go about it, right?
In horizontal integration, when temporal coordination comes also, how to avoid repetition, madam? Because the pathology people are also taking the same topic, meningitis. They have been teaching in the same thing. Whatever we are teaching, the same thing they are also teaching. We have to reduce that now. The
Yeah, you
repetition
can share.
should be
You
reduced.
can share. This is where sharing will come in. Okay, you have just one. We can have just one class. We can have just one class and look at all the competencies, the sub-competencies, objectives, combine, and then do it. Because meningitis for meningitis pathology will be speaking. I mean, talking about the different aspect of meningitis. When it comes to the
Okay,
if
same
you're
platform.
yeah.
Okay,
Hello.
means same class should be shared by 3-4 disciplines, and 20 minutes each they will be talking about their part. Is it the sharing?
No.
Is it sharing?
When we are talking about integration, we are not talking about integrating faculty. We are talking about integrating the topic. Okay, so
Okay.
it is possible
We
that
are teaching
beforehand,
in our class. We are
yeah,
teaching in our class, madam. And the
yes, I
pathology
know
people
that.
are also something again.
I
How
understand.
to
So that is what. Let me finish, madam. Let me just finish what I'm trying to say. So whenever we are
okay.
trying to share any topic, lot of groundwork and lot of pre-class session work has to be done amongst us. So pathology and the
Yes.
microbiology. Can you hear me?
Yes.
Yes.
So we all
Yes.
need to
Yes,
sit
madam.
down together and work out the session if we are talking about sharing.
Yes.
And if you feel the need that two teachers need to go to the same classroom, it's not that it cannot be allowed, but I mean that will depend upon the comfort level of the particular teacher. Okay.
If you
So
think
there
about the learner, if you think about the learner perspective, will
are
it
right.
be easy for the learner to cope up if it is start like a piecemeal, half here, half there, like that?
It won't be piecemeal. It cannot be piecemeal. I mean, how do you
Yes.
think? Can you give a yes? Anybody who would like
CSF,
to add? Because
Hello.
CSF parameter, CSF parameters we are teaching in our class only in lab diagnosis. Like pathological biochemistry also we are telling them what are the
so
parameters of
eh,
CSF.
right.
That is
In this
easy.
case,
Yes,
what we can do is we can just align it. On the same day, we can have one class of microbiology, second class of pathology, and maybe another class of pharmacology.
Uh,
So it will
may
be
I,
gradual and it won't be piecemeal.
yes.
okay, okay, okay,
So how you
okay, madam.
design
Okay,
your timetable, it will depend on
okay.
that
We
also.
have to arrange. We have to arrange like that.
Yes.
The classes
Yes.
also
So
we
it
have
will
to
be,
arrange exactly so
yes, you
that
have to
the
arrange
same
like
day.
that. Yeah. Same day or in the same week. That is what temporal coordination means. It means that with time,
Yes.
within the same time frame, in the same time frame, we are teaching an entire topic. It could be the system based or a disease based. If you take meningitis as a topic, then you can have the entire thing covered up over 1 day, 2 days, or depending, like how you all decide. Okay. So then it
Yes.
will be very gradual.
Yes.
If you are talking about the etiology, then pathologists come in, then the pharmacologists come in. And maybe at the end, you can have a class of correlation with a case from medicine, right?
Yes. Yes.
Uh,
Yes,
Uh,
madam.
uh,
Uh,
Hello.
okay, madam. Thank you. Thank you very much. Thank you.
I would like to add something to that. See, basically, when we talk about this new curriculum, remember that it is not possible to achieve 100% initially on the first go, right? So, as what Madam said, integration does not mean integration of a teachers. That is the very first thing. As far as possible, we should go for temporal coordination, and where possible, we go for the sharing. Remember, there are competencies which are given in the booklet, which is supposed to be integrated. So there are competencies of pathology which are given in microbiology, and there are competencies of microbiology which are given in pathology. So best thing is that you visit that department, have a common meeting, and decide that who is going to talk about what, right? So this is the
right.
way we can reduce the redundancy, repetition. It can be reduced. That is a way out. And most important point is that the entire integration or competency-based curriculum, we are talking about systems or organ, right? It is not about staphylococcus. It is not about pneumococci. So we talk
Yes.
about system or organ, but the only problem is that when we come to a- assessment, right? If we don't change our
Yes.
assessment plans and if we are going to ask the same question, laboratory diagnosis and
Yes.
pathogen of staphylococcus, everything will come back to step
Uh,
number.
yes. Yes.
So, Dr. Prerna Bhalla.
Good evening. I've been waiting for a long time, and my main query is the presentation was excellent. I understood for the first time that what is integration, what is alignment. I must say, Dr. Prakash has taken an excellent presentation. The other thing
I
Thank you,
also I must agree with you, ma'am. I have seen the presentation for pharmacology also, pathology also, but this one
Mhm.
was the most clear.
Oh, really nice. It was really nice.
Yes.
Now, the only problem comes in implementation of this alignment and integration. I discussed with the phase 1 subject heads in our medical college, and they said alignment was nearly impossible. Number two, they said integration was being done by sharing the PowerPoint. What PowerPoint? For example, physiology prepared, they would share it with the others to see what aspects that they have covered are acceptable to anatomy and analysis. I'm giving an example. So they were only sharing PowerPoint, not being able to align, at least in our medical college, hardly they could align in phase 1. So I'm also worried about the phase 2. Alignment is something very difficult. Systems, diseases can be aligned. But otherwise, integration, we will share our PowerPoint with Department of Medicine, for example. Clinical manifestations they should go through our treatment modalities. We should not emphasize on treatment or clinical manifestation. We should emphasize all about the etiology and the organism. That is my feeling. What is your comment on this? Yes, please, I'm waiting for your response.
Should I answer, ma'am?
Yeah,
Please.
please go ahead. I'll join you after that.
Okay. Yeah, ma'am. Actually, as you said, many of us have misunderstood what is alignment and what is integration. First thing.
Exactly.
Yes, ma'am. Second thing is, many of us don't want to do that.
Oh,
The
that is true.
administrators in many colleges are not giving the ample time for the MEU to come out with their own things. They are forming their own things, and then they say you just follow this. So I know this year it's going to be very difficult to follow all these things, horizontal or vertical integration. But by next year, every college will have a proper horizontal and vertical integration, ma'am.
What about alignment?
Alignment also it's very easy, ma'am. We can do it provided our MEU team, which is there in our college, they take up little bit of pain in the initial stages, and then they convince the administrators.
Okay.
Ma'am, I have
So
taken almost 1 week to prepare this PPT, ma'am.
okay.
Yes, ma'am.
And
So
yeah.
yesterday night I slept around 2 o'clock. So it's
Oh
not
dear.
easy to do something. It's not easy to do something over the day.
Very good.
Until unless we take some pain, it will not come out good, ma'am. We need to go behind administrators, pester them, and then we get our things what we want.
The MEU team has to play a very active role. The MEU team has
Yes, ma'am.
got to play a very active role. So I will pursue with them now for trying to design it in such a way with the curriculum.
And
Yes, ma'am.
there's one more thing I would like to add. If you are done with what you were saying,
Yes, please. Sorry, I will
ma'am.
not
Okay.
interrupt.
No, there's no question of interrupting. In fact, I am interrupting. No, there's also something about, like when all these years we were very rigid with our timetable, the routine that Monday को school लेना है, Tuesday को school लेना है, मेरा class अब है, तब है. But when we are talking about this competency-based curriculum, be changed because we are talking of alignment, the entire timetable will look very different. We have to make it week wise, maybe there would be a lot of changes. Otherwise, it won't be possible to, do proper alignment. Everything may change, except for, maybe the practical classes and all where we will have fixed time. Other than that, yeah, because every competency will require, if we are aligning, it will require a different approach. Like today, we may start with pharmacology in some topics and maybe microbiology one day and pathology the next. So there has to be a lot of admixing of classes. Every week, the pattern won't be same. That is how I understand, and that is how we are preparing actually.
I
And
think we
that's
all
true,
have
madam.
to be very flexible, meet our other subject colleagues very frequently when we plan our lecture. They plan their lecture. I think we should learn, we will have to learn to interact a lot with the other subject colleagues.
Yes, ma'am.
May I add something, madam?
Please.
Yes, sir.
Yes.
Madam, what you said is very right. What you said is very right. The first thing, as Dr. Prakash has presented, the Harden's 11th step of integration, right? And this is the opportunity that till now we were teaching in isolation. And this is the first time we are worried that what is happening in other subject. At least your department, the preclinical first year department, has started sharing their PowerPoint, right? That is the first step towards the integration.
Yes.
Although it is not scientific, but they are now aware that something is happening there and we are supposed to take care of that. It is going to take many years to go for fully integrated curriculum. But at least now we are worried and we are trying. Definitely it is going to come, right? At least the first year subject are teaching various systems in a particular time frame manner. For example, January they are taking respiratory system, which is there everywhere. Then GIT, which is there. So this is some sort of integration which is coming up, right? So that is we are positive for that.
Thank you very much for answering many of my queries. Thank you so much.
Thank you, ma'am.
Dr. Raj Hans. Dr. Nagaraj. Well, you are self.
Am I audible?
Am I
Yes,
audible,
yeah.
sir? I'm Dr. Rajan.
Basically, meningitis as an example, as microbiologists, we will be telling about the etiological agents, different etiological agents, and the virulence factor. For example, the pathology person is going to actually correlate with the changes that are going to occur in the pathological tissues. That is a meninges and other thing. It changes. I think this is the type of integration. Am I right, sir?
Yes, yes.
And for treatment also.
there is too much of a noise from someone's
Yes,
mic.
sir. Lot of disturbance is there, sir.
Coming from
Similarly, pharmacology, when it comes to treatment, it all depends basically on the virulence factors and things like that, which will be integrating together, and departments can sit together and discuss and come out with a consensus how to make the student better and better to understand the subject.
That's true. That's true.
This is what I feel.
Yes, sir. That
Thank
is
you,
the
sir.
ultimate aim. That is the ultimate aim.
Thank you, sir.
Dr. Raj Hans.
Hello.
Hello.
Yes, sir.
Hello. Am I audible, sir? Hello.
Yeah, yeah, please.
Yes. Thank you, Prakash, sir, for such a nice presentation. Sir, my doubt
Yes,
is
sir.
related to nesting and sharing, sir.
Yes, sir.
Sir, during our faculty development programs, I remember the observers suggested that the nesting and sharing can be done by that particular subject person only. Like if you want to share something from pathology, a microbiologist can talk on that for his whatever basic knowledge related to that topic is with him. So is it practically true, or we should not do such things, because a pathologist always knows better than a microbiologist when we want to share? I'm talking about the thing which we are going to discuss with the students. So if a microbiologist talks about pathologist part in the sharing or nesting in his own class, okay, or the expert should only talk, or the share presentation should be talked? Thank you.
So, as per the references what we have taken, sharing is
Yes,
two
sir.
departments are going to share the class.
Okay.
So there, two teachers are going to come. They are going to discuss what they are going to present and what these persons are going to present, and reduce the repetitions, and then they are going to present. That is sharing.
Okay, sir.
Nesting is what we are going to take some of the topics which we can say, and we are going to refer that. This is
Okay,
what
sir.
pathological things are. So there, we are just mentioning the other departments. Like for example, if it's a higher grade, we are going to introduce. If it's going to be a lower grade, for example, meningitis, we say LPCB will be done. Sorry, LP will be done for meningitis.
Okay.
Then we are going to go to anatomy and we are going to reintroduce or reinforce. Where is the
Okay.
which part of the body we do the LP, and then what is the necessity and why only there? These are the reinforcing from anatomy. Whereas if you go to
Okay.
the higher things, clinical course things, we are going to reintroduce that. This is called as nesting, sir.
Okay,
Whereas in
sir. Okay,
Yeah,
sharing,
sir. Got it.
if I can add
two
to
teachers come together and then they do the PPT presentation for 2 hours. If it's a 1 hour class microbiology, 1 hour pathology, they come, they
Okay.
discuss the topics, clarify what they are going to do, these people are going to do, and then they take the class together. That is sharing.
Okay, sir. Got it, sir. Got
No,
it.
very,
Thank you,
very
sir.
right.
Thank you.
What you said is a good example of that. I can give one more example. In a rabies class, as for example, we teach clinical presentation of the rabies. So it will be a type of a nesting for a medicine or a pediatric, right? Over here, you can
Yes.
see we are not teaching them in detail about what are the clinical presentation, but we at least say that what is happening, right? Sharing is rightly said that you are sharing a stage and different department come together. For nesting, you don't need teacher to come over here and say that, right? You can definitely say that. Yes, very right, sir.
yeah, and nesting is all about you're re-emphasizing why you are learning this. For to a first year student, if you're giving them a clinical picture or anything, an example, they will understand better that why they are being taught this particular, like carbohydrate metabolism. Give them an example. Why do they need to learn? So that is nesting, that you are bringing up a phase 3 portion into it, giving them relevance. Basically, you are bringing in relevance of why they are learning all this, which actually it does not make sense to them otherwise. So it is all
That's true, ma'am.
absolutely about bringing in relevance. And when in phase 3, the same thing, when you are teaching them, supposing a class of hydrophobia, maybe they will be taught then also in phase 3. So you're talking, bringing in this microbiology part a little bit. It's an envelope virus. Then why do you need to do this first in the beginning? Because you are using soap and water because it kills the virus. So these are some reinforcing things, so that they will be reminded of what they were taught in earlier classes. That is nesting. Very simple. We are already doing all this, isn't it?
Yes, yes, yes. Informal way and
Thank you. Thank you. Thank you so much, sir. Sir, madam, everyone. Thank you.
Thank you, sir.
So, no more hands. Anybody
okay.
wants to ask any question? No. There are a lot of congratulatory messages from Raghvendra Rao, Sai Leela. Excellent and wonderful presentation. Very simple. Hats off, Dr. Prakash. Please
Thank you,
share
sir.
your
Thank you very much.
thanks to Dr. Rao.
Thank you.
I congratulate Dr. Prakash for a very good presentation, for a very good example when I think about implementation. I get many doubts. One comment I would like to make that when you go in for NAAC accreditation, there is something known
Yes,
as
sir.
multiple learning opportunities, for which NAAC gives
Okay, sir.
marks.
Okay,
And
sir.
so I feel that these multiple learning opportunities, they are beyond the classroom.
Yes, sir,
That
that's true. That's true.
okay, you have a computer lab where certain things are being done for self-directed learning. There is a uh, one room having only TV where videos are being run. There is a session going on. So of say poster making on a particular topic involving multiple subjects. So all those methods of multiple learning opportunities where some kind of integration is possible, they will all have to be channelized. And if you
Yes,
read
sir.
the NAAC
That's better
document,
idea, sir.
that makes it compulsory. I mean, this is the MCI document, but if you look into NAAC document,
Okay, sir.
so that gives us some food for thought.
Sure, sir. We will check into that, sir.
Right, sir.
Yes.
Thank you, sir.
So really, I mean, it was an excellent presentation, Dr. Prakash. Thank you.
Thank you so much, sir. Thank you
We
so
can
much, sir. Pleasure, sir.
we can end it now. Dr.
Yes, sir.
Very good
Swaminathan.
presentation.
Yes, Dr. Swaminathan is coming with the AHP lectures at
Yes, sir.
7. You can attend that also.
Sure, sir. Sure. I will attend, sir.
Sure. Okay. Right.
Okay.
Okay.
Okay,
Thank you,
thank
sir.
you.